Welcome.
No, I'll be back.
So we ready to go?
Welcome. I'd like to introduce Dr. Wouter Ritsema, who's going to be doing a gourmet lunch today on Hospital Quality and Safety Report Cards 101. I do need to let you know that the session is being recorded, and today is July 26, 2012.
So good morning, everybody. It is still morning. So how many of you saw Consumer Reports? Yes?
Yes.
Okay. For those of you that don't read Consumer Reports, I actually get it electronically on my Nook, but I hadn't read it before it came. I didn't read it when it first came out, and then I got the issue plopped on my desk. Anyway, Consumer Reports did a story in their latest issue called "How Safe Is Your Hospital?" And what they did is they actually rated actual individual hospitals in their, they released 4 different editions across the country regionally, and so our edition was the Northeast edition, so they rated hospitals across the Northeast. I don't know exactly how they drew the borders. So they didn't rate every hospital in the country, because what they did is they used publicly available data, and the data that's available publicly varies state to state. And many states don't have a lot of public data, and so they didn't describe their decision-making cutoff, but in the end, they only actually rated 18% of hospitals in the entire country. But anyway, we were a little lower than average in their single score. I don't know if you're familiar with Consumer Reports, if you read Consumer Reports, but when they rate vacuum cleaners, you know, they usually have a series of categories of criteria, and you can get a full black circle, which is very bad, or a full red circle, which is very good, and then there's gradations in between, half black, half red, and then an open circle. And then they somehow mesh that all together to give you a numeric score on a grade of 0 to 100. And so the highest score across the country that they gave by their rating system was like 70, low 70s, and it ranged all the way down to the teens. We were 39. Fletcher Island was 45. Central Vermont was one of the highest in the country. They may have been the highest in the country. The Cleveland Clinic, who U.S. News and World Report considers the 4th best hospital in the country, according to their thing, came in at the same score that we did. So, you know, it points out some issues about report cards, and I'm not going to sit there and defend us against the report card, but just explain all the different report cards that are out there. So, this is just a few of the report cards. You know, we report data to CMS, and you can find that data. You can go on the internet, the www.hospitalcompare, all one word, .gov, I think it is. Just look up Hospital Compare on Google, you'll find it. And that started out of the original IOM report in the late 90s, 1998 or 1999, at the 100,000, where it said that every year, you know, 100,000 people die as a result of medical errors. And then in 2001, there was a follow-up report that said, how do we fix this? And there were a number of pieces to how do we fix this. But one of the pieces was public reporting of hospital quality and outcomes data. And that's when CMS started publishing that data. They started making us report data, and that's when they started publicly reporting it. And so they're sort of, they're the main driver of this. Many states also have publicly reported data, and certainly DOH is in many ways ahead of the curve on that. It's not as easy to find. You can find it, but it is out there. But then you have these other, you have the Leapfrog group, you have health grades, which you may have heard of. One interesting publicly available report card is the Commonwealth Fund Commission on High Performance Health Systems, and they release reports that you can find on the internet. The Niagara Health Quality Coalition, actually, they just take New York State publicly related data and put it in a yearly report that they release. But it's really just the data that we report to New York State. So there's all sorts of stuff out there. So, you know, again, CMS, we have New York State, then you have private for-profit report cards, the most prominent of which is Health Grades, which, have any of you ever been to healthgrades.com? Yeah, so they rate doctors and hospitals, okay? And J.D. Power and Associates, we're all familiar with them from cars, they also rate health plans and pharmacies. I don't know, I thought I remember reading somewhere that the two of those might eventually merge together, I don't know. But they're for profit, okay? And how does anyone know how Health Grades makes their money?
Advertising.
How do they, what do they do?
Well, and if you read on the sides, there's all sorts of pharmaceuticals. And
On the website, there's advertising, but that is not their prime revenue stream.
I don't
So,
know.
but it is advertising. So if you do well on the Health Grades report, which is publicly available, then for a fee, you can use that in your marketing, okay? And that is not cheap. And if you do poorly, for a fee, they'll consult with you to improve your numbers, okay? Now, interestingly, most of their consultation work has nothing to do, actually, with improving quality. But it has to do with improving documentation and coding to make your patients look sicker. Therefore, in risk adjustment models where you adjust for the sickness of the patient, your patients will look better. And that's not an unrealistic issue. That is a huge issue. Most good data is risk adjusted because certainly a hospital like Fletcher Allen is taking care of many much sicker people than a hospital like us, but much an even greater disparity. Looking at the type of people taken care of by Adirondack Medical Center. So clearly, you know, outcomes are it's gonna be easier to have good outcomes if you take care of less sick people. And the way they control for that is the other illnesses that people have, and that comes down to coding. And where do they get that? They get that from coding, you know. So their model, they're not out there for altruism. They're out there to make money. And they basically will sell consulting or advertising based on how you do. And then you have the private not-for-profit consumer reports, and they are a not-for-profit. And of course, their mission is to provide information. I haven't read their mission statement, but at the end of the day, they need to sell magazines. That's what they're about. The Commonwealth Fund is probably they're out there purely, that was started by a private foundation called the Commonwealth Foundation. Someone with a lot of money decided that, one of the ways to improve quality was to report data, and so that's their mission. And I had never heard of them before I put this together. And I've been to their website a little bit, and they just take publicly reported data and try to report on it. And Leapfrog, I didn't put Leapfrog on this list. Does anyone know about Leapfrog? Have you heard? Do you know how Leapfrog got started or why it got started? So big corporations like GE or the various car manufacturers, they're self-insured. They own their own insurance plan for their employees. They don't go out with, Empire but they're self-insured. So, they were concerned with health costs spiraling out of control. And so, and they knew that at least some of the health costs were due to poor quality. So they put together, they came together and said, what can we do to influence quality? And so they reviewed the literature, and it's pretty old. I mean, Leapfrog probably is 15 years old at least. They reviewed the literature about what things are in the literature that are supposedly important to improving quality. And at that time, they looked at things like 24/7 staffing of ICUs. They looked at computerized physician order entry, and they looked at doing procedures based on volume. In other words, there are certain procedures where we know that the more you do, the better you are at it. Pancreatic surgery, things like that. So they looked at, do hospitals that do pancreatic surgery have adequate volume, or things like that. And they would collect that information. Interestingly, though, they just reach out to the hospital and ask you, tell us your numbers. They don't take it from publicly reported data that's validated. They just would do surveys of hospitals. So all of these report cards have different audiences and different agendas. It might be to sell magazines, it might be to sell advertising, it might be to sell consulting, it might be to inform the public. And really the agenda that they have is going to a certain extent, drive how the data are aggregated and presented and scored. I think I would like to say, and I think that CMS tries to look at what's evidence-based and what matters. They look at mortality and infections and also the evidence-based process measures, and more they're focusing on outcomes too, like mortality and readmissions and things like that. But how the data that are out there in the public realm are then put together, mishmashed, and created into a quality score is really up to the individual reporter. Consumer reports or health grades, they do it different ways. And again, that's going to, they're going to present the data in a way that meets their needs, their business needs. Okay. So again, where do they get the data? Well, a lot of them just do data mining. Health grades, for instance, what they do is they get access to what we call Sparks data. And our Sparks data is our billing data. When we bill, we send data to New York on every patient we take care of about their primary diagnosis and all of their additional diagnosis, all of that coding data. That is publicly available data. Not necessarily right away. They can get, after a year or two, it becomes publicly available. So Health Grades gets that data. And then they also get data from the Social Security Administration on mortality. In other words, Social Security, I guess a year or two later, they'll tell you which Social Security numbers are for people that are dead. And they just match the two things up. And most health grades data is based on mortality. They just look at mortality after surgical procedures, mortality after heart attacks, and things like that. So that's what they do. The New York State publicly reported data, they can just get off their website. It's often a year or two old. They might get data directly from the facilities. Leapfrog gets the data from hospitals. Every year they send out a questionnaire to hospitals, and hospitals can decide to tell them to answer the questions or not. We don't bother participating in Leapfrog. It was really much more relevant for big cities, big urban populations, and big hospitals. And it's not relevant to our area. And they do different things. They have different risk stratification models. How do they account for the fact that some hospitals have sicker patients than others? How do they do that? And there's all sorts of different ways to do that, and they all have different ways. And they may or may not actually be what's called proprietary, but be transparent about that. They may tell you what their ways are, or they may not. Health Grades doesn't tell you what their risk stratification methodologies are, because they don't want people to. They want to tell you once you pay for their consulting services, and they won't tell you what the risk stratification model, but you can guess what it is based on what they tell you to do to make your data look better. So they're not telling people to lie; they're just telling people to do a better job of identifying how sick the patients are. So, and if when you see these report cards, they all look at different things. They may look at process data. Process data are how well do we do things that are supposed to make people get better. And that would be like our core measures. How often do patients with heart failure get proper discharge instructions? How often do patients with pneumonia get the right antibiotics at the right time? Those are process data, and that's what we report to CMS. And some of the scores look at that. More and more, they're focusing on outcomes data. Mortality, either across the board or for selected diagnoses, readmissions, which of course is it's a quality measure and it's clearly a financial measure. Readmissions cost money. Infections, I think there's no doubt that is no one would argue that is not a relevant measure of quality. Complications and hospital-acquired conditions, do people get pressure sores? Do people fall and injure themselves? Efficiency measures, CMS is starting to look at efficiency measures, they're looking at, and we don't report this at all, they just look at billing data, and they say how often, when one of the ones that was in Consumer Reports was, when we get an abdominal CAT scan, how often do we get it with and without IV contrast? There really are not very many situations in which that's necessary. Why do hospitals do it? Well, those are like two separate x-rays that you can bill twice. So, you know, there are efficiency, but there are also radiation exposure in that case. You know, do you really need? No, you don't need it. So you don't need that much radiation and things like that. So more and more we're starting to see efficiency measures in CMS. And Consumer Reports did include that in their report. Patient satisfaction, clearly, everybody is interested in that. And I think, you know, it is clearly a measure of how satisfied people are with their care. And it has a very direct link to quality in that patients who are satisfied with their care tend to be more adherent to what we ask them to do. And then structural measures. This is Leapfrog started this, and they've been doing it by questionnaire. But we're starting to see in the upcoming in CMS's pay for performance. There, it looks like in a couple of years, one of the pay performance measures will be CPOE, I think. Is it? No, there's another structural measure that I can't remember what it is. Oh, use of the surgical safety checklist, the World Health Organization surgical safety checklist. Do you use it? Okay, that's a structural measure. That is an evidence-based measure that does improve outcomes. So that will be a yes/no. Do you use it or not? And that will affect our payment. That's not solidified yet, but that's what they're proposing. So, you know, what happens is a hospital can look like $1 million in one report card, and they can look poorer in another report card for all the reasons I mentioned. First of all, report cards look at different things. So clearly, because not all hospitals do everything well. It's quite frequent that they do some things well and other things not as well. Or, you know, how they put it together. If they decide to give you a composite score like Consumer Reports does, depending on what they count and how much they count it. You know, like when you go to class, the exam's worth this percent and the homework's worth this percent. Well, depending on how they do that, your composite score could be different. They also look at different time frames. Depending on the data they look at, if they're relying on publicly reported data off of the CMS website for core measures, that data is not even available till it's at least 9 months old, 9 to 12 months old. And then if they have to take it and crunch those numbers, you're talking at least 1.5 years to 2 years old data. Certainly the Consumer Reports data, some of that data is at least 2 years old. And lastly, how do they risk stratify? Or do they risk stratify at all? And that's going to explain variation for a single hospital. You know, then, but within a report card, there's, you know, how to explain the variation. You know, there clearly are actual, real variations in quality. I mean, I think we know that. You know, Consumer Reports, we got a full black circle in the patient satisfaction, and that was questions from the HCAP survey. And the fact of the matter is that on the HCAP survey, we're in the bottom 20%. Now, the fact of the matter is that in the HCAP survey, on a scale of 1 to 100, the vast majority of hospitals are clustered between a score of 70 and 80. And the average score across the country is like 75, and we get like a 73. There's not a lot of variation, but we are in the bottom 20%, and so we get a black circle. Variations in documentation and coding practices. You know, the hospitals that have for years have been very aggressive about collecting every possible comorbidity in their coding tend to look better because their patients look sicker, so in a risk stratification model, they're going to look better. Variability in public reporting of data. I mean, the Consumer Reports, they rate hospitals based on data that is state reported. Well, New York State has a lot of state reported data, and some states don't have as much, and the definitions of the data might be different. What New York calls an infection, and what New York calls a colon surgery infection might be different from what New Jersey calls it, and Maine might not look at that at all. And then there are, you know, this is a thing across all measures of quality that's a real issue, in that there are many measures of quality, even in hospital mortality, that appear to vary depending on factors that are totally outside of the walls of the hospital itself. socioeconomic class of the population served. I think that's pretty obvious to most. Much of that, but not all of that, would be captured in comorbidities, but not all of it. Non-hospital care availability. So if there's a shortage of nursing home beds and you can't get patients into nursing homes that really should be in nursing homes, they're going to have a longer length of stay in the hospital. Well, if you look at patients that are, nearing the end of their life, who may be DNR or even comfort care, if they die in the hospital, that's an in-hospital mortality. Okay, if they die in a nursing home, that's not an in-hospital mortality. So, so clearly the availability of how much hospice penetrates into. So certainly if you're in a region where patients, and this often varies by socioeconomic class, but not completely. If you're in a region where hospice is very, very popular, very well penetrated into the community, and patients choose to be at home to die, then you're going to see a lower in-hospital mortality. Whereas if in some regions, patients are much more comfortable dying in the hospital because they can't handle that at home. So that there's definite variation there. Also, regional variations based on state policies. There might be policies about various things that drive certain behaviors in states and hospitals. One of those has to do with not so much quality measures, but New York has always required that patients leave the emergency room within 8 hours. And so that means you either have to discharge them or admit them. Whereas if you could keep them in an observation status in the ER for a day or two, they might get better and you could send them home and they never would have been in admission. So that may not affect quality measures, but certainly reflects reimbursement and things. And those things, there are lots of things like that that vary state to state that might affect mortality measures and things like that. Also, attitudes. If you look at Press Ganey or Gallup or anybody that surveys hospitals, what you'll find is that there is fairly significant variation regionally in patient satisfaction. The northeastern United States has the lowest patient satisfaction in the country, and it's worse in New York. New York's patient satisfaction is the worst in the country. But the Northeast as a whole is the lowest patient satisfaction, whereas the Midwest tends to be higher. Now, if you look at hospital financial stability, you find an association there. The Midwest tend to be the most financially solid hospitals. Hospitals in the Midwest frequently make anywhere from 6 to 15% margin or profit a year. Hospitals in New York, half the hospitals in New York lose money a year. Is there a correlation? Is there a direct cause and effect? I don't know. Is there an association? Yeah. Is that accounted for in any of these things? No, it's not. So that could explain variation. So how do we deal with these report cards? These come out all the time. They come out in the news, WCAX. I don't know how many of you saw the story they did on the TV about the Consumer Reports. How do we deal with that? So internally, from what I say, we internally we need to ignore these report cards. We need to focus on what we report, and we need to focus on doing better at what we need to do better at. Partnership for Patients is the CMS program that overlies so many of the quality measures we're working on, whether it be catheter-associated UTI, whether it's pressure sores, whether it's patient falls, whether it's readmissions. All of these things are things we're working on. And we just need to keep working on and keep getting better. As long as we do that, if that's the data that all these other report cards use, we'll be fine. We can't control how they risk stratify it. We can't control how they choose to weight it. That we have no control over it, so why worry about it? Let's just focus on the publicly reported measures, and those are the measures I mentioned. And really ignore the report cards, internal. And externally, we need to, Stevens always talks, we need to partner and collaborate with the other healthcare agencies in the community. How do we better use home care? The more we use home care, the less length of stay is. The less length of stay is, the less likely a patient is to die. The better the home care is, the less likely they're going to be readmitted to the hospital. So we have a new home care agency. We need to collaborate with them. They're very interested in that. It's a new day of home care in our community, so we need to work with them. Because at the end of the day, we're doing the right thing for patients. Medical home is going to focus on, is really making a difference in readmissions and ER visits and better primary care. That's going to improve overall health of our community and will improve our quality. You know, once our affiliation moves forward, assuming it passes all of the regulatory hurdles, you know, we can start working on Fletcher Allen Partners system-wide quality initiatives. Our patients move back and forth between us and Fletcher Allen. We don't have any joint quality initiatives to really make sure that all of that movement is the right movement and they're not moving when they shouldn't, and coordinate access and care. That will improve. And obviously, if the press calls, we respond to the press. They didn't call us, even though CAX did this whole story. They never called us. They spoke badly of us, but they didn't call us. And no one in our community, none of our local news organizations called us at all. So, it's not like we were eager to trumpet it. But so, and really, you know, you can talk about a composite score. And whether your composite score is 39, which doesn't look so good, or 72, which still isn't that great, but is one of the best in the country, to the individual patient, that score has no meaning. The only thing that matters to the patient is what happens to them on a given day when they come here for services. And we're really, to that patient, we're only as good or bad as their most recent experience with us. And day to day, every individual interaction, whether it's helping people in the hall or what's happening on the floors or when they come to get blood drawn, that's how, whether we're good or not, is how we take care of that patient, how we deliver quality, how we respond to that patient, how we meet their needs. So, questions about report cards? Shall I get them?
Mm-hmm. Water, I have a question. We have a fairly good handle on this and can understand it and can balance out when a consumer report comes out like that. How do we handle it when our members in the community don't understand all of this? And they read that or they hear that on the news?
Well,
you know, that's a hard.
You know, as we get inquiries, you know, certainly, you know, we chose not to do anything about the consumer reports thing. Fletcher Allen, who didn't fare terribly well, either chose to do something, which was to say, you know, to say, look, we want to do a follow-up story and we want to talk about these, you know, and their approach was, look, we're always working to get better. We know that there are areas where we can improve. But they also, to a certain extent, pointed out some of the challenges in these reports. And, you know, my first argument is the whole consumer reports issue across the country and all the regionals scored only 18% of hospitals.
Right.
Well, and you would say, well, that doesn't, you know, it's still, maybe that's a good representation. And I would argue it's not. If publicly reporting of data promotes improvement, which I believe it does, because actually consumers don't look at those websites, but we do. And we look at it and we say we need to get better. And if you look, since public reporting of data occurred, scores have improved over time. And I do believe the healthcare industry is getting better. If that is important, the reason they didn't include the other 82% is because there wasn't enough data. In other words, those hospitals are not subject to reporting. If you're not subject to reporting, your focus is not as clear on the things that you're reporting as it could be. So I would argue that one could make a case that quality in those hospitals represented in the Consumer Reports article is in fact better than those hospitals not reporting. That their eye is on the ball more because, you know, we have to, because that data is out there. It's very hard to explain the details of risk stratification and stuff like that.
Yeah,
But the major points are, look, it's only 18% of hospitals. What data they looked at is totally different state to state, and it's all old. You know, it's very old data, at least 2 years. Some of that data is probably older that they utilize. You know.
Is there any effort to eventually get to where you're comparing apples to apples?
Well, I think that's where CMS comes in. I mean, you see CMS more and more is asking for more and more reporting. And at least with CMS data, it tends to be validated. Everybody's using the same definitions. You know, even New York State is, for its infections, is trying to stick with NHSN definitions.
Except that we just got something from Partnership for Patients, and they're not using that. They're using the Sparks data, which is billing and coding, and
Right.
the doctor writes something that makes it so, and without the comparison. So
Yeah.
it's frustrating. And
It is, you know, and that's why, to a certain extent, I say ignore the report cards. Just keep trying to move forward, have fewer infections, do the things that we need to do, and trust that eventually the system will sort it all out. So, I mean, the reality is that still a minority of patients that are using this kind of stuff to make their healthcare decisions. They expect us to get better. They expect us to work on it, and more they're holding us accountable when we don't, through complaining, talking, whatever. But they're not out there, you know, mining this data, figuring out where they go for care. We're looking at it, and we know that other places are, but I think we ought not to get too worked up about the report cards per se. Just keep doing what we're doing.
Does anyone else have any other questions for Dr. Ritzma? Well, I'd like to thank you for coming today, and I'll also like to mention that the lunch has been provided through a generous grant from the foundation. And if you didn't get the opportunity to grab a lunch on your way in, please feel free to grab a lunch on your way out. And thank you for coming.
If you haven't taken